look into the faces, I can feel that many people are wondering if I'm going to give the talk in English or in French or in Arabic, right? You don't need the headsets. I'll make it in English, yeah. So thank you very much, actually, for the opportunity. And so you need to really to be trilingual to follow actually all the sessions, right? So you would like to get the joke, right? Start with a joke, yeah, just to relax. Yeah, you know, if you speak 3 languages, then you are trilingual. If you speak only 2, you're bilingual, right? But if you speak only 1, you are American. It doesn't apply to you at best because I know that you speak Persian and Turkish as well. Yeah, right. Thank you. So let's get started here. So these are my disclosures here. And yeah, let's get started with this nice picture that we have seen actually illustrated by Professor Arabi. The first FDG PET image which dates back to the 1976. And yeah, Abbas Arabi has been my mentor so for a number of years, and he basically stimulated my interest in quantitative imaging. And the advantage again of PET, as he mentioned in his brilliant talk, is that you see the numbers on the left side, is that you can quantify something that you can remove during using anatomical imaging techniques. And I really actually encourage you actually to read this very nice biography written by our colleague Poul from Denmark. So Professor Alavi turned 80 in when? 2018. So this means that he's 87 years old. So in this particular country where people start thinking about retirement at the age of 50, I think it's really a nice example. So yeah, keep working till the last day of your life if you can afford. Right, so to talk about quantitative imaging, we start defining what we mean about quantitative imaging, and I think this is a very nice definition given by the Quantitative Imaging Biomarkers Alliance, which is a group actually created by the Radiological Society of North America in the US, and they say that quantitative medical imaging is defined as the extraction of quantifiable features. So we're talking basically about imagery-derived metrics that can be used actually for clinical diagnosis, monitoring, treatment response, radiation therapy treatments, planning, and a number of other applications. So this is the official definition. And it is slightly different from what Dr. Lopsy, so the star of this meeting, has shown in his presentation. What you see is basically so 2 seamlessly different bars with different intensities on kind of shaded gray that you see here. And if I bring the 2 bars close to each other, you realize that they have exactly the same intensity. So this is one of the limitations of the human visual system, right? And most of the MDs actually, they prefer to interpret visually the images, but I think this is a nice example that the human visual system might trick you in some cases. So why do we need quantification? We have another quiz here from a nice illustration from our friend Professor Buller, or his mentor actually, so but he's co-author of this publication. You know that when acquiring the data, we can acquire dynamic frames, and we can also sum up the events collected with a certain time period to get kind of static image, and this is what is used in the clinic nowadays. And if I show you this image here, so the same subject, it's a healthy subject which has been scanned twice, baseline, and then after the administration of aprepitant, which is kind of an antagonist which binds actually to the KP1, PK1 receptors. So if you look to the static image, actually baseline and after administration of the antagonist, and they ask you actually to basically give me what is your sense of the occupants in the AQ1 receptors in these 3 atoms. Is it going to be less than 25%, 50, 75%? I think to the naked eye, the physicists are inclined to see less than 50%. And this slide has been shown actually during many conferences, and most of the audience, actually including experienced PET scientists, they usually say between 50 and 75. So if you use tracer kinetic modeling, and then build these parametric maps that you see here, and then we quantify actually the binding, non-displaceable binding potential, you see is that it's in the range of 97%. So quality which is definitely much, much higher than what the human visual system is given to depict based on the static image. So how things happen in the clinic is that most of the facilities that I know, including ours, so we tend actually to interpret qualitatively the medical images, right? And the criteria actually for qualitative assessments of the medical exams is to have a good quality image. And most of the MDs actually are trained to differentiate between normal biodistribution that you have in the brain for FDG and the patterns which is typical actually, this is these hypoperfusions that you see typical of the neurodegenerative disease, basically Alzheimer's, dementia of Alzheimer's type, right? And the same can be said also for whole body imaging. So this is the normal biodistribution that we have for FDG, right, with 6% given to the brain, 20% probably given to the bladder, and the rest is distributed somehow in different organs. And this is the typical pattern of lymphoma, right? And then the second step actually is to proceed also to what we call semi-quantitative analysis, and this is basically the standard adopted for multicenter clinical trials. Phase 2 trials actually conducted by the pharma industry, where they need to scan different patients in different locations and those different places. Usually they use different scanners, different brands, and different acquisition reconstruction protocols, and they need some form of harmonization actually to be able to harmonize the data collected on the different sites using different patients and different acquisition protocols. And this is one of the good reviews that we recommend on harmonization. This also applies actually to clinical sites where we've got one patient scanned on one PET scanner for the baseline, and then you decide to change the scanner to get another one with higher performance, and you need to harmonize the data so that you can compare the baseline to the follow-up scan rate. And this type of techniques is used in the clinic, at least in our department. A number of such tools actually are commercially available. I'm not going to name the manufacturer of this tool, but basically the idea is that you get a PET scan of one patient, and then you have a normal database, what we call templates. So basically age and gender-dependent human subjects that undergo, normal subjects of course, that undergo PET scans, and then you realign them, and then you constitute what we call a template or normal database, and then you can do the comparison between the patient's specific PET scan with respect to this template. This can be carried out on a voxel-wise basis to get the deficient area, which is different actually from the normal database. We can also define a number of regions, right, on the MRI, so that you can do the semi-quantitative analysis basically on region by region basis, actually for 63 regions. And the same type of techniques are also employed for myocardial perfusion imaging. In the context of clinical oncology, so we have seen many numbers in the previous presentations today, and the idea is basically to define region of interest on the malignant disease, and then you quantify what we call the standardized uptake value, which is given by the Seeley equation that you see here. It's basically the ratio of the activity concentration in the malignant disease divided by the activity injected to the patient, normalized actually by the weight of the patients. And because we've got a number of voxels within this region of interest, so we can do some simple statistics to get the average, to get the maximum, or even the peak standardized uptake value as recommended in the PERSIST criteria. Some people actually use also what we call the TLG, total lesion glycolysis, provided that you get the metabolic serum volume. You can multiply this by the SUV mean to get this TLG, and sometimes the weight is replaced by other factors such as the body surface area, lean body mass index, and so on. So the good thing is that 90% of the sites, according to a survey published in GNM a number of years ago, reports the standardized uptake value in the reports, and this is the case for our institution as well. And the SUV max is usually reported, and we have seen many of these numbers actually in the previous slides. And the bad thing, I think, in my opinion, this is the bottom line, is that this SUV max reflects only one voxel within the whole lesion actually that can be defined. And the bottom line again is that this SUV depends on many factors, some of them linked to the patient's physiology. We need to ask the patients to fast a number of hours. Not all of them respect this. Blood glucose levels as well. So some other factors linked to the instrumentation, actually the acquisition conditions. For instance, one factor which is often neglected is that in our institution we use automated dispensers, and the clock of the automated dispenser has to be synchronized with the clock of your PET scanners, because otherwise your bias actually is going to reflect this difference in the timing, because the two clocks are not synchronized. And then you have a number of other factors that are summarized here, which can go up to 50-70% in some of the cases, right? So the last tool that is often used in research applications but not used in the clinic is full kinetic modeling. And usually this is well known to compartment model for FDG. It's like fluid mechanics, right? So the one compartment reflecting actually the flow from the blood to the tissue, and so on. So we have the microparameters K1, K2, K3, and K4, and then you need to have the input fraction, which can be estimated in many different ways. You can get the blood samples, you can get image-derived input function, and this allows you actually to get the parametric maps that I showed you earlier, or again what you see here. Right, so in terms of image quality, actually, you know that PET-CT suffers from a number of physical degrading factors. This includes attenuation, Compton scattering, partial volume effects, and I'm going to talk about this later on. And then, so these are some of the different artifacts that we observe in the clinic. So these misalignments between the X-ray CT and the PETs, because of the differences in breathing patterns, you know that we can acquire an X-ray CT for less than a few seconds, especially if using 128 detector rows, and then the PET is usually acquired between 2 and 3 minutes per bed position, so it reflects an average of large number of respiratory cycles, and then you might end up with this banana or cord artifact that you see here. People doing X-ray CT, the radiologists, they know that these metallic artifacts that we encounter very often, especially if you have dental implants, if you have large prostheses, you end up with these large artifacts that can get propagated actually to the corresponding PET image, because we use those CT images for attenuation correction of the corresponding PET images, and this might end up with this artifact that you see here. And then the same can be said for IV or all contrast media, if this is used for attenuation correction. Truncation artifacts, I think this is very common in the US because they usually scan high BMA patients. It's rarely the case in our facility because usually the patients have very low BMA in Europe. How to sort out all these problems? I think we have assisted really into a revolution in the medical imaging, like the tsunami in medical imaging, the use of AI for medical imaging, and some of these tools using AI can be used to sort out all the problems that I just mentioned. I'm going to show you a few examples. So we have an extensive discussion last year. So just to show you some examples, Isaac, one of the former PhD students in my lab, he developed this comprehensive framework which enables to get rid of the majority of artifacts that we encounter, including misregistration, metallic artifacts, the hollow artifacts, which we see very often in gallium-68 PSMA imaging. And let me just show you one example. This is one of the examples from our facility. You see the X-ray CT, which is mismatched with the attenuation corrected PET image that you see here at the level of the lungs of the diaphragm here. And this is an artificial intelligence based attenuation correction technique that doesn't use the CT for this purpose. So it's kind of direct conversion between the incorrected and the corrected image. And you see that this PET image is nicely matched actually with the X-ray CT that you see here. Another example, this is the hollow artifacts. So which is kind of miscorrection for Compton scattering and an overestimation actually with the scatter component, where you see these huge artifacts in this region, low uptake in this area here. And what the MDs usually do is that they tend to re-scan the patient, repeat the exam, hoping that this artifact is going to disappear. And you see that the artifact is still here for the second acquisition. And the deep learning network is really doing a good job in this respect, in the sense that the artifact is not visible in both scans here. We also care very much about the radiation dose delivered to the patients, and this is another study actually by Yazdan, other PhD students in the lab. So this is the regular CT scan that we use in our facility for attenuation correction purposes, delivering almost 3.1 millisieverts actually to the patients. And we have a nice tool actually provided by Siemens, which adds kind of noise-dependent or scanner-dependent noise to the regular CT scan or the standard dose scan to get these low dose scans at different dose levels. And this is with the factor of 30 reduction, so only a couple of MAS for requiring the CT scan, because obviously we did not scan the patients twice because this is not ethical. And this is the one predicted by the deep learning network, so almost similar image quality is what you can see here, but with a factor of 30 reduction in terms of radiation dose to the patients. You can see that even from this example, even the small structures here got preserved on this low-dose CT scan, so something which is extremely reassuring. And we look also to the impacts, because these CT scans are used for pattern attenuation correction, making sure that the bias is not significant in terms of standardized uptake value quantification. It gets really down from 80% when using the low-dose CT scans to up to less than 0.5% when using this developed technique. Partial volume is definitely an important physical degrading factors, and this is a comprehensive review published again with having Professor Alavi as one of the co-authors on this review, because he is one of the first physician scientists who got interested in this partial volume effect. So this is how we can explain it actually to non-physicists. If you just scan a number of spheres with the diameters given from 4 to kind of 16 millimeters, and playing actually with the what we call the point spread function, or the spatial resolution of the scanner, which ranges in this case between 4 and 10 millimeters. So this is a simulation-based study generating actually this simulated PET image, and you've got the impression actually that the contrast decreases actually for the smallest sphere, when in reality we have the same contrast in all the spheres. So with this we end up actually with this curve for what we call the recovery coefficient, which is defined by the activity concentration measured actually on the image by defining a region of interest on the sphere divided by what we injected really what we measured on the dose calibrator and injected in the sphere. So we got this shape actually of the recovery coefficients. And one of the well-known actually techniques to compensate for partial volume effects is to basically reverse the recovery coefficient to compensate for, provided the spheres actually have spherical shape, of course. And we have been using actually this MRI-based partial volume correction in our clinical collaboration with the neurologists since almost 15 years, and this it basically segments the MRI, so number of intermediate steps that I'm not going to discuss in this presentation, and then you correct this image that you see here. These are two patients, and this is dementia of Alzheimer's type, where we demonstrated that the hypometabolism here extended beyond the atrophy, and this is a frontotemporal dementia case where the hypometabolism basically coincided with the atrophy. So giving some important information actually to the physicians to decide about the cases using partial volume correction. In cases where MRI is not available to do this type of corrections, Amir, another PhD student in the lab, developed this artificial intelligence-based technique, which consists obviously, as you might know, two steps, one for training, the second for application on unseen data sets. So we have a couple of cycle GANs. So this is one of the most popular neural network architectures that use for medical image analysis. And we have two basic cycle GANs consisting of a generator and discriminator that does this job. And this is basically the outcome. You see the MRI for different tracers, FDG, tau, amyloids, and DOPA. You see the MRI, the PET image, which is not corrected for partial volume correction, the MR-based partial volume corrected image, and the one corrected with the artificial intelligence network. So I think we're really still within this in crisis in terms of PET quantification, because there is no consensus. We have seen different numbers, SUV mean, SUV max, TLG, whatever. So we'll be talking about radiomics and parametric imaging. And I think it's difficult for the young scientists, young physicians to really choose among all the metrics which are available, which one is going to be used. So we have different types of metrics. The first order metrics are quite simple. like the SUV max, the SUV peak, the second order matrix, the SUV mean, which is extensively sensitive actually to the partial volume effect, the MTBTLG, and another metric which has been pioneered by Professor Alabi called the global metabolic burden. We have the high order matrix, which is called radiomics or textual features. 5 minutes more is okay? All right, 5 minutes, all right, very good. So and then we have parametric imaging, which is a specialist's best friend. I think the tumor heterogeneity has been reported in the major publications as bearing prognostic factor, and unfortunately for the community actually focusing only one voxel, which is the SUV max, we're not taking into account this heterogeneity, and it has been also demonstrated in a number of papers that if you go from small uniform actually uptake to larger with lesions with heterogeneous uptake, the larger heterogeneous lesions are going to be more resilient to therapy. And then it's, I think, really unfortunate that we are only considering one voxel to characterize the disease. This includes also our institution. The MDs already reports only the standardized uptake value max, and this is what is used actually to decide if the patient is responding. This is basically the typical plot for a patient responding to a therapy and another patient which is not responding to the therapy, and unfortunately this patient died after a few weeks. And so it's really unfortunate that we discard all this important information that can be used actually for prognosis or for outcome prediction. And this is actually what has been advocated by Robert Julius, who unfortunately passed away a couple of years ago, who has been the father of this concept called radiomics. Because images are more than pictures, they are the data. And the idea of radiomics is that you basically segment the malignant disease to be able to extract what we call the gross tumor volume, and then we extract the number of features that could be either intensity-based, shape-based, or texture-based. And with the texture-based features, we can build what we call here the heat map, which is extremely difficult, I can understand, for MDs. And this is probably one of the reasons why radiomics has not been implemented or adopted in clinical settings. Just to show you some of these examples, more morphological features, you can look actually basically the solidity, which is low in this case, a high for the green case, and this is the rectangularity, and this is the sphericity. We can get also the histogram, not really meaningful because you can get different histograms reflecting the same biodistribution. And some of the advanced high-order metrics include what we call the gray level co-occurrence matrix, where we basically express how combinations of discretized gray levels of neighboring voxels are distributed along a certain distance. And with this, we can actually extract what we call the entropy, the energy, a large number of features that can be extracted from these features. If you look actually to the publications, this is a nice review paper, probably not up to date, but still I think the information that it carries is important in the sense that the largest number of articles published in radiomics, 77%, uses a small number of patients, less than 100 patients, and only through actually used more than 200 patients. So there is definitely a need actually to pull data from different studies, from different clinical sites, and the problem with radiomics is that they're very sensitive to the type of scanner, to the acquisition reconstruction protocol, so it's difficult because you get two different biodistributions. And a good technique that has been actually applied in the field is it's called combat, which basically enables you to pull data coming from different sites, different scanners, using basically some techniques developed for the analysis of genomic data. And to standardize actually the way we extract radiomics, so the IPSI, the Image Biomarker Standardization Initiative, has done a good job actually publishing a couple of papers in radiology a number of years ago. So this includes a pretty large number of academic institutions, over 25, who have actually basically standardized the reporting and interpretation of these radiomic features. And for the students and also for the physician scientists interested to do radiomics, to use radiomics in their research studies, a number actually of open source software can be used for this purpose. And the most popular one is probably the one coming from Harvard called Pr ZAIDI. So if you look also to PubMed, I just did this this morning actually before coming to the conference. You have over 3,900 publications using radiomics in the papers, and so if you look to the trend, so really the number of papers is exploding and following an exponential. Again, so just a couple of minutes. I would like to draw your attention to this study actually by Yazdan from my group. So what he did is basically to extend this concept of radiomics to intra or to peritubular tissue, so by extending actually the GTV by 1, 2, 3 centimeters. And then he also segmented the healthy organs and included this in the analysis towards the concept of what he called organomics, which is basically organ-based radiomics. And then he used these nice data sets for small cell lung cancer. And then he combined different feature selection techniques with machine learning models, looking actually to the GTV on the CT, on the PETs, and including also the healthy organs. And he ended up actually concluding that the largest C index or concordance index could be achieved actually by using this concept of organomics combining both PET and CT. And obviously this leads to better discrimination between low risk and high risk patients, as you can see from the Kaplan-Meier curves here. Let me just skip a couple of slides just for the sake of time to talk about this concept of parametric imaging. As has been alluded, so we're moving actually from short axial field of view PET scanners to large axial field of view PET scanners up to 2 meters long. And there are different ways actually of doing parametric imaging depending on the scanner which is available to you. If you have a short axial field of view PET scanner, this is a nice methodology. Basically scanning the patients for short acquisition time per bed position, putting the patients exactly in the same position as was done initially, and then you start the second scan, and with this you can scan the patients multiple times, ending up with a large number actually of dynamic scans that can be used actually as an input for a tracer kinetic model to derive the kinetic maps. So we can do this with a simple graphical analysis using the PATLAC analysis with or without the K-loss, which basically if you have a reversible or non-reversible tracer. And you can also do this already at the with the full kinetic model to extract all the microparameters. So this is basically the standardized uptake value image, which is acquired in the clinical setting. And these are the parametric PATLAC maps, so basically the influx rate and the distribution volume that can be acquired. And one of the scanner manufacturers is offering this as part of the software provided to the end users. We have demonstrated actually in clinical study that full parametric imaging might be useful in some cases. So this is a case with hepatocellular carcinoma, where you see that the SUV image is negative. And the K1 and K2, some show that these really positive cases. And by the way, just as a comment, so I think nuclear medicine is the only specialty I know where the physicians are very excited and they'll be happy when the scan is positive. Something which is astonishing, but I've been observing this since a number of years. So this is positive on the K1, K2, but negative on the SUV image. And obviously, if you have a total body PET scanner, you can actually get, immediately after you inject the patient, you can get the tracer uptake basically in the patient, different components of the uptake, and you can also derive the kinetic parameters, including the delivery rate, which you can show here, distribution volumes, and all what you are interested in. So let me just skip the summary, actually, just for the sake of time. Let me thank the funding bodies actually funding our research, my team actually that you see here. Special twink for those who graduated recently, getting their PhDs. And then, as I said in the beginning, so I think the Persians, after Professor Olabi, are still leading the field. So two of my former PhD students, Persians, so this is Isaac, who got the Bruce Hasegawa Award this year in Japan, and this is Abul Fazl, who graduated in 2015 and who got the Bruce Hasegawa Award in 2018 in Sydney. So the Persians are still leading the field. And delighted to have you here, Professor Olabi, and thank you very much for your attention.
Thank you, Professor. Thank you.